Hello and welcome to the New Jersey update webinar. The topic of today's webinar is going to be pediatric TB meningitis challenges and opportunities. So we're going to start today's webinar by just doing a quick review of some of the surveillance data from New Jersey. The time period that I've chosen for this really brings us up to date. And so it's a little bit unusual that I'm covering 70 months. It's just short of 6 years worth of data ending October 31st, 2014. When we look at the pediatric TB in New Jersey over the last nearly 6 years, well, first let me say that the total number of cases counted was just short of 1,967 cases counted in New Jersey. Among those, 82, or 4%, occurred in children less than 15 years old, which is the definition for pediatric meningitis that we'll be using today. And it's also CDC's definition of pediatric. I've included one slide here from the CDC's surveillance data set from 2013. You can see it's in line with what we see nationally. If you go back several years, every year is nearly 5%, 4.8, 4.9, 5%. Of the cases nationally occurring in this age group. So very similar to what we see here in New Jersey. And again, I'm sort of hitting highlights here. You know, one of the things I looked at was of those pediatric cases, 82. We see that the vast majority of pediatric cases in New Jersey are occurring in U.S.-born children. Since 2009, we've been collecting here in New Jersey and, of course, nationally, the country of origin, or country of birth, the primary guardian of these child TB patients. So what you sort of see is, you know, in this slide, we're looking at that 83%, that was 70 out of 82 children were U.S. born. So I thought it'd be interesting to look at the country of birth of the parent, or the primary guardian. And you see this sort of inverse proportion here where of these 70 children, 83% of them had a primary guardian who's foreign-born. Also, when you look at the demographic profile, we look at race, ethnicity. You can see that the majority of these child case patients were Hispanic. In terms of site of disease, I've included this frequency table. And interestingly, again, when we look at these 82 cases, more than 2/3 of them we have documented in our TB registry as being pulmonary TB. If you look at all the different sites of disease that include pulmonary, from 80% of these children have pulmonary involvement, or at least that's what our data reflects. And we only document what's sent in to us at the state health office. I know that the topic of today is TB meningitis. You do see that the numbers are fairly small, but we'll talk about that. Here I've broken out the cases by age and by site of disease. You can see that the majority of the cases are occurring in the young age groups, children who are less than 5 years old. And surprisingly, we saw that most of those we have documented as pulmonary TB alone. So that, again, it's interesting. I can only tell you what the database reflects. We saw very few cases in the older children, and all of those were extrapulmonary. I also thought it might be interesting to look at what is the primary being evaluated. And when you look at those who presented with TB symptoms, which is more than 1/3, and if you include those with the children who were identified, that covers 2/3 of all the pediatric cases. Surprisingly, few children were identified through the immigration medical. Very few, only 3 over the last nearly 6 years. But again, remember, most of the pediatric cases, the vast majority were U.S. born. Some may not have primary guardians who were foreign-born, but they're likely to have one who is foreign-born. Verification data, this is how many of these children, and remember, very few of these children have, I'll mention earlier too, that none of the pediatric cases over this time period were documented as being HIV positive. Many of them were not tested. Very few of these children had any at all of drug resistance. In fact, only 4 children in the cohort of 82 who showed cases, so I just lumped those all together as clinical. Very few had the traditional sputum culture positive that we normally see with adults. And then, well, nearly a third had a culture result from another specimen. Most of these were the gastric ribs and cerebral spinal fluid. Now, with that being said, I did take a look at with our TB meningitis data. Again, the numbers are relatively small. So this is the time period here. We see 10 cases reported over the time period. So interestingly, 7 of the 10 were reported within the last 22 months. So this is something that really got our interest here in New Jersey. We spoke a lot here at the Global Institute and spoke with CDC. And that's really going to be what one of the case studies we'll see today has to deal with. In 2014, you see 4 cases reported. Actually, 2 of these are siblings, same household. That's going to be what one of our case studies is today. This is that slide we looked at earlier where we showed age at diagnosis as well as site of disease. I just wanted to show you where the TB meningitis cases occurred. So 3 cases occurred at extrapulmonary site of disease, so TB meningitis alone, 3 children who were very young. And we saw, in fact, all 6 of these had TB meningitis. These all the green boxes all say there's 6, so all 6 of those TB meningitis diagnosed along with pulmonary TB. And then lastly, we saw just 1 case. Yes, sir.
Cases that you have, be they have culture or not, is every one of these children, adults associated or contact that you can see together? They've gotten it from someone.
So specifically the meningitis cases?
No, just in general.
I would say most likely yes, but I haven't really looked at the data. But yeah, generally yes. Because,
I mean, with Eric, those 24 we have cultures for, we obviously would have the link in terms of knowing transmission, because we actually have the cultures for at least 29% of them.
Yeah, that would be interesting to look at because some of the studies published suggest that you don't often find a source case when you have even a case of TB in the house.
Well, when you look at the meningitis cases alone, and those are the ones we really look at closely, we did find an adult with TB, with pulmonary TB in the house who went at least 2 of the cases. 2 of them had recent overseas travel, and I believe 1 had a relative who returned to Haiti who was undiagnosed. So that's a pretty strong link. Again, we see that, generally you find, I don't know what the number would be for the proportion that we see where the actual verified source case is located. Remember, most of these children do not have culture identification, so we don't have genotyping. But we do have some pretty strong correlations. The case study that's coming up later on is going to be a good example of what you see, public health getting involved and really making a difference.
Excuse me, Karen Galanowski. I know that there was one of those cases of the children that we did not find a source case. This baby traveled back to Haiti for 3 months, was sick a little bit before she left, and the aunt in the house where she was staying in New York City went back to Haiti and subsequently died of a respiratory tract infection. So we think that might be the source case, but we could never find it. Mark Wallman did a thorough contact investigation along with the Lattimore practice staff and the nurse case manager and the field workers in the daycare center where the child was, tested everyone, looked high and low for a source case in New York City with the family. We couldn't come up with anyone, but all the others, we were able to identify 1 person, adult, at least 1.
Thanks.
Right, and you're going to see an example of that in that case study that's coming up out of Ocean County, which is pretty much textbook in the household between adults and children and siblings.
Thanks, sir.
So, I mean, I guess the thing I was going to point out here was that, and it's important to note that, and it's not surprising to think that, nearly all of the TB meningitis cases occurred in children who are less than 5 years old. Actually, from some numbers of the risk ratio, and I saw that the children who less than 4 years old have 7 times the risk of presenting with TB meningitis than older children. and that was actually implemented. It wasn't for the 1 5-year-old. So I did the same thing with the TB meningitis cases. Again, I know it's small numbers, but just to see what country of birth of the actual case patients. Again, all of these children are U.S. born. All but one. The one that was not U.S. born was actually born in Mexico. So look at race of ethnicity. Again, we see it overwhelmingly Hispanic. In fact, all were Hispanic except for two. One, again, was Haiti. And the green box said, excuse me. The red box, Vietnam. The green slide is Haiti. All the rest, Hispanic, Mexico, Central and South America. We're looking at the country of the primary guardian, and that they were all foreign-born. So that's what we ended up with. You see, I just listed the countries there. The majority of them from Mexico. And when you add in the South America and Central America, it's nearly all cases except for two. Again, one from Haiti, one from Vietnam. So, I mean, really, I kind of just want to get the highlights of the data. I mean, I don't have a lot of time, so I know that sometimes when you present limited data, it prompts more questions and answers. But hopefully some of the speakers that are coming out will fill in some of the blanks. Here's some quick facts that I listed. Again, we're talking about TB meningitis in New Jersey, but the good news is that just when you look at pediatric TB overall, you know, while this age group represents nearly 20% of the population, they account for only 4% of all cases. They over time period was nearly 6 years. There's very low incidence rate among persons less than 15 years old in New Jersey. And again, this is true for the nation. Mortality is extremely rare, mostly zero, although there was a couple instances noted over the last 6 years. But still, mortality is less than 1 million population. And again, no person in New Jersey who's 15 years old or less has died with or from TB. 2010. With all of that being said, it is important to understand that pediatric TB and or pediatric TB meningitis can occur at any time and any place. And we've certainly seen that over the last 2 years. This is a quote that I've included here from the Harvard Medical School to further emphasize the importance. Where again, our numbers are very low, but just one case. And I know all the nurses that work closely with these cases have been affected. Some of these are very sick children. In fact, most of them are. And we certainly don't want to see that. So I'm not trying to minimize that but I have to show you what the data looks like. Again, very small number. Introduce the first speaker here today, Dr. George Sherry. At Penn State Children's Hospital, he's chief of the Pediatric Infectious Disease Department.
Thank you for that kind introduction and that great epidemiologic review.
Good afternoon, everybody. Thank you for inviting me to talk about pediatric TB meningitis. I'm going to focus, as you can tell, on diagnosis and treatment. As you're all aware, and this is sort of a quote from a number of sources, Edith Lincoln, Peter Donald, and a host of other people who've dealt with pediatric TB for years, but TB meningitis in children is the most dreaded complication of tuberculosis. It's actually the most common cause of death from tuberculosis in childhood. Fortunately, in New Jersey, our deaths are few and far between, but that's not the way it is in other places, particularly internationally. In the pre-treatment era, the average duration of meningitis from the onset of symptoms to death was 19.5 days before we had treatment. Now, in the treatment era, complete mental and physical recovery depends upon early diagnosis and prompt treatment. This requires something you'll hear me say quite a bit about this afternoon, a high index of suspicion. The suspicion is one the sick child you're dealing with, and you'll see how this gets missed, actually might have meningitis, so you pursue that, and if you pursue that, the consideration that the meningitis might be tuberculosis. Finally, as a result of a variety of reasons, diagnosis is often delayed, and we end up with severe sequelae, even in New Jersey. Okay,
briefly, I'll cover the following areas. We'll talk briefly about transmission of tuberculosis to children, because that sort of sets up your source case and index case. Searches the risk of tuberculosis disease by age in children, the pathogenesis of TB meningitis, its clinical presentation, diagnosis. Clearly, we know that children are usually infected with the TB bacillus by an adult or an adolescent in their immediate household. Depending where you are and what the epidemiology is and the prevalence, it may come from outside the household, but mostly it's from inside the household. So if we're looking for a source case, the child who presents with TB meningitis, we're looking in the house first. And then we're looking with all the people associated with that. And in our source case investigation, one of the things that a clinician has to remember when they're in front of a child and the cues, the questions they should be thinking if they're thinking there may be TB meningitis is there anybody in the family with tuberculosis? Is there anybody in the family with symptoms and signs of TB disease? Is there anybody in the family with risk factors for TB? Is there anybody who comes from a high-burden country? They may reside locally, and they may be somebody who visits periodically for overseas. These are just a start of some of the questions that you want to ask if you're suspicious that the child in front of you has tuberculosis. This is data that Sandy Newton published based on data that was put together by Ben Murray. And this is the risk of tuberculosis disease by age. And if you look at the, we start with children less than 1 year of age, you can see that if they become infected with the TB bacillus, 50% of them don't develop disease, but 50% do. And in that 50% that do develop disease, 30 to 40% have pulmonary disease, mostly standard primary tuberculosis disease. 10 to 20%, this is a huge number, can go on to develop TB meningitis or disseminated disease or biliary. And we look for the second year of life, and the numbers are lower, but they're still quite high. 10 to 20% of children will become infected with TB bacillus, will develop pulmonary disease. 2 to 5%, again, a large number, will develop disseminated disease or TB meningitis. And then sort of we move along where the numbers are a little lower, between 2 and 10 years of age, but there still are cases of meningitis in that age group due to tuberculosis. And finally, we move to the adolescents who have their own way of doing things, as we all know. And when you get through puberty, right around the time a child goes through puberty, there's an increased risk of development of pulmonary disease. And we've seen a number of cases of TB meningitis in that age group, and those are usually quite severe. But mostly today we're going to concentrate on the young children. That's what measures the risk. So how long after a child is infected with TB bacillus are they at risk of developing TB meningitis? So this is data from the timetable of tuberculosis after Waldron. Arvid Waldron was a Swedish pediatrician who studied tuberculosis in orphanages from the 1920s to the 1950s. He put together a tremendous amount of very useful data. So if we look at the bottom line here, what you can see is that's the time to conversion of the skin test in months. And then if we look at the third box here, which is biliary disease and TB meningitis. So child's infected at point 0, and by the time about 2 months comes, you can see that they've already, that tuberculosis can develop before the second month after infection. But by 2 months of age, you see there's a huge upswing in the presentations of TB meningitis. And that continues elevated. Usually 2 to 6 months are the high risk. Once into all parts of the central nervous system. And this happens early on in primary TB infection. Now, meningitis does not result from direct seeding of the meninges during this process. But what happens is those TB bacillus, what they find their way into the brain parenchyma itself, and multiple foci are established of these bacilli. And what happens is some of them lodge near the cortex of the brain, which is the outer rim of the brain, and it's those that begin to replicate, begin to multiply. And when they do that, they push their way upward to try and get out of the brain parenchyma. And eventually what they do is they infect the pia mater, which is the layer of the meninges. There's 3 layers to the meninges that covers the brain. Infects that, and then once they infect their way through that, they dump TB bacillus and the caseous cabbage cheesy type pus that comes with TB disease into the subarachnoid space. This is an example. This is from a paper from Pediatric Radiology. This is an MRI, and you can see small caseous foci in various places in the anatomic structures of the brain. And those are the ones that rupture through and start the inflammatory process that's associated with what we see in TB meningitis. So this is a schematic of here's the brain, and so the caseous foci have the bacteria replicate, and then they sort of move their way up into the pia, and then dump themselves into the subarachnoid space. So here's the subarachnoid space here, and once it gets into there, you've already got some minor symptoms in this area replicating, but it gets into here, so we really start to see. This is a pathology cut from Johns Hopkins, and you can see this was a caseous focus here that grew outwards and sort of dumped down into the subarachnoid space. So this was such a large amount of tuberculous bacilli that was dumped into the subarachnoid space that the patient died from acute infection. That's not the usual course. Now, not all caseous foci of these bacilli cause meningitis. Some of them get walled off, as you can see in this case. This is a 16-year-old girl who presented to us with multiple tuberculosis. These lesions get walled off, and usually nothing happens. So occasionally what will happen, as you can see on this side, is one of those walled-off lesions, the capsule has broken down and dumped the caseous material into the brain, and this is an inflammatory response of edema that has occurred that left this child with a right hemiparesis because of damage to the brain. With treatment, steroids and TB medication should recover completely, but that's what can happen to these kind of lesions. And that's what happens to some of the other foci in many of the patients that we see. So when the caseous material and the TB bacilli get dumped in the subarachnoid space, they form a thick gelatinous exudate. And what this exudate does is sort of wheedles its way into the lining or the walls of the meningeal arteries and veins, and produces inflammation, more caseum, more pus, and obstruction of the veins and arteries. And then what it does, it'll extend along those small vessels into the cortex of the brain where it really causes damage. Because if it causes obstruction of the small vessels in the brain, it leads to infarcts, or the common term being strokes, which is of course the most severe sequelae that we see oftentimes in children. The other thing that the exudate can do, it's free floating, so it's in the CSF, and what it can do, it can line, so cerebrospinal fluid is produced on a daily basis, continually, and then some of it gets produced and other gets absorbed out, so there's a constant equilibrium of the amount of cerebrospinal fluid we have. Well, when you get this gelatinous exudate, what it'll do is it'll block the bodies, the pachyonian bodies that allow for reabsorption of the spinal fluid. And what happens is the spinal fluid builds up. When the spinal fluid builds up, you get what's called hydrocephalus. The ventricles enlarge. You get symptoms like headaches, seizures, and other things. And that's a heavy proteinaceous exudate. And what it does is, with gravity, it falls to the base of the brain. And on the base of the brain are where the cranial nerves come out, including and especially cranial nerves 6, 3, and 7, and that's where the optic chiasm is, where the optic nerves cross. And that heavy gelatinous material goes down and it presses on those nerves as they come out of the brain and causes nerves, which is why we'll see in a minute a 6-nerve palsy and nerve palsy and loss of vision. So what happens? What's the clinical presentation of a child with TB meningitis? I think the major thing is that it's a non-specific presentation, at least at the beginning. A child shows up and has vague symptoms, fever. If they're a little bit older, they may have a headache. They may have some vomiting. They may be more sleepy than usual. And so a clinician is faced with the fact they have a child with non-specific symptoms. And in the era where we don't see much meningitis, first of all, the clinician may never think of meningitis at all. And we don't see much meningitis because of immunization. Never mind thinking about TB meningitis. So that's one of the problems we have. So that index of suspicion is very important. And most clinicians these days have never seen tuberculosis or not dealt with it on a regular basis, so they don't think about that. And what what happens, therefore, is they miss the cues. They miss the fact that the child's from Mexico, or the parents are from Mexico, where there's a lot of TB, or they're from somewhere else where there's a lot of TB, or there's somebody standing there coughing and looking cachectic. So they miss some of those cues and don't think about TB disease. Now, the sort of history that you get when you talk to the parents is the onset is kind of a slow, insidious onset, usually over 3 to 4 weeks. Child was fine. The other interesting history you get is, well, he was fine till he got a cold, and now he's here and he looks awful. Well, or he fell down and hit his head, or his brother hit him with a pillow and he's here. So it's all these, and it's really across the board that you hear these stories. The other story that you get is, we went to the doctor 5, 6, 7 times. We went to the emergency room a bunch of times, and they were discharged, and the diagnosis was always an upper respiratory tract infection, or if they're vomiting because they've moved to stage 2, they have gastroenteritis. Sort of to follow that along in a natural progression, the Medical Research Council back in 1948 devised a staging of TB meningitis, and it's sort of the one we use today. There are 3 stages. The earliest stage, if you catch a child in the earliest stage, make the diagnosis and treat them, they do fine. There's usually no sequelae. They recover quickly and do very well. And the presenting symptoms at this time, there's some key ones there. One is a change in behavior or personality. The normal, smooth, very nice little child becomes irritable and angry and is throwing things and biting and hitting. And so there's a change in behavior. They're irritable. They don't eat. They're listless. Some of them may have fever. Older children may complain of an awful. And after 1 to 2 weeks of that, they begin to develop the signs of increased intracranial pressure and cerebral damage. And by the time you get to the second stage, even if you jump in and treat appropriately, oftentimes there are significant neurologic sequelae. But the presenting signs in the second stage, drowsiness, nuchal rigidity or a stiff neck, cranial nerve palsy, vomiting, unequal pupils, and convulsions. And finally, if you get to stage 3, usually it's a full-fledged disaster because the patient will be comatose, have irregular pulse and respirations, high fevers, and palpability. But continuing on the difficulties in diagnosis, again, non-specific symptoms, poor appetite, perhaps poor weight gain. One of the things to always remember, a child's not gaining weight in the differential diagnosis, even in the United States, should be tuberculosis. Certainly everywhere outside the U.S. it is, but it certainly should be here. We know that miliary meningeal disease mostly occurs in children between 4 months and 4 years of age. One of the handicapping features, although it should never dissuade us from thinking that the patient has TB disease, is that the tuberculin skin test can be negative, and as mentioned, 50% of the cases of TB meningitis. And the other thing that always often gets forgotten is looking for I call it the epidemiologic link, the adult source case, and ask those questions. If you suspect TB in a child, and you can find an adult who has TB or looks like they have TB or has risk factors, then it sort of reinforces your clinical ideas about what the diagnosis might be. Other questions you want to ask at the time, again, it's the same thing. Child and parents' country of birth, visitors to the home from that country or from other places, homemakers from a country of high prevalence, or nannies from such countries. Things but you have to suspect meningitis to begin with, and you have to think about TB based on the cues that are placed in front of you. On the other hand, there may be no index case or source case because the incubation period from infection with a TB bacillus to the development of TB meningitis can be so short that nobody's identified the infectious adult in a household. Again, you want to maintain a high index of suspicion. There's no actually excuse not to, and all these variables are in play, and you should think about them. This is the ubiquitous source case.
So, George, if you had to differentiate other bacterial meningitis from TB meningitis, what would be the key?
So how do you differentiate? That you cued into this very good. I don't know. Because that's the next slide. So how do you differentiate the two? So you get the typical child. You say, this child has meningitis. You do a spinal tap. It comes out. It looks like it's meningitis. I'll show you some more tuberculosis-specific CSF values in a minute. But on your clinical exam and your imaging, and everybody gets imaged before we do anything to them these days, these are things that suggest you're meningitis. If the tuberculosis, if you have cranial nerve involvement, 6 cranial nerve, patient can't look to the right or look to the left with their eye. Do they have hydrocephalus on the imaging that you do? We'll look at some of those pictures in a minute. And then finally, when you do your imaging, you do contrast, is there inflammation at the base of the brain? So there's 3 things that really help a lot. The other thing you can do is a chest x-ray, which people often forget. We got meningitis, but they don't do a chest x-ray because you may see classic signs of primary tuberculosis in that chest x-ray. But it's really those 3 things: cranial nerve involvement, hydrocephalus, and basal meningitis. If you have a child with meningitis and you have those 3 things, it's TB meningitis to prove it's something else. So this is a 11-month-old girl who presented to the emergency department in status epilepticus. This is a growth chart up here to show that her head circumference was way above the 97th percentile for her age, which is consistent with hydrocephalus. Now, she seized for 2 hours in the trauma bay in the emergency room. Finally, she stopped. The CT scan was done quickly, and he noticed hydrocephalus. You can see these are the normal ventricles of the brain. Normally, they look like this in the middle cut here, very, very small and slit-like, and here they're obviously very large. So the neurosurgeons inserted an extraventricular drain in the emergency department to relieve pressure, prevent her from seizing further. Now, again, in the classic, so this is hydrocephalus. That's the first thing. The second thing is, several days later, when she was a little more stable, they did an MRI with contrast. This is an MRI, and if you look at this area of the brain here, you can see it's hypodense. It's a little darker in color, and that's an area of vasculitis. And vasculitis in a child with TB usually is consistent with an area of infarct. So at 11 years of age, she developed an infarct there and was paralyzed on the right side of her body for the rest of her life. That did not come back. And if you look at this other cut, this white area here is contrast that has pooled at the base of the brain. So that's basal meningeal enhancing. And these little dots here, little white round lesions, are tuberculosis. So she had the full cadre of disease. When we did a chest x-ray on her, she had pulmonary infiltrate, and she had a 6th nerve palsy when we examined her. But it took 2 days for the infectious disease service to be called. So she sat in the intensive care unit undiagnosed for 2 days. Her CSF, interesting, was not very typical of TB meningitis. So this is a 6th nerve palsy. This is a older patient of mine. She cannot turn that eye to the outside. It's her left eye, and she's looking to the right. The 6th nerve is involved, so she can't put it to the outside. That's one of the cranial nerve palsies. This is another young man who presented at 18 months of age, seizing. And if you look up here, here's his brain, and this is the corpus callosum, which is very important in many of the brain functions. And you can see his corpus callosum is not nice and smooth; it's all torn up and destroyed by TB meningitis. And he's got a big tuberculoma sitting right there. So that's pretty typical. He's got hydrocephalus in here too. You can see the ventricles are very large. About 50% of children who present with TB meningitis also have miliary disease. This is a case of severe miliary disease. You can see the miliary lesions throughout the lung side. When we do a lumbar puncture in such patients, sort of the standard teaching is okay, how do you differentiate TB meningitis from other meningitides? And this holds to a certain degree, and I'll explain what I mean. So theoretically or classically, there are a number of lymphocytes in the cerebral spinal fluid. So there's a predominance of lymphocytes, somewhere between 10 and usually and sometimes thousands. The protein can be elevated, and the glucose is low. So lymphocytes, high protein, low glucose usually signifies you should be looking at TB for TB disease. The problem with this is sometimes there might be 12 white blood cells, lymphocytes, which means there's probably meningitis, but you don't go and say, gee, this is TB meningitis, so it can be a little misleading. And then you might look at the protein, and it might be 95 or 96, which is elevated, but it's not 2,000. And the same with the glucose. It might be 40 or 45, but it's not 2. Although, if you wait long enough, the protein will be 3,000, and the glucose will be 2. And the lymphocytes will have the right number. So those are just things that we look at it, but you have to be aware of the limitations. What about the mycobacteriologic diagnosis of TB meningitis? In children, we have about 50% of the cases will have a positive CSF culture. It's paucibacillary disease, so it's really good when you have an isolate from the CSF, but oftentimes we do not. In such cases, if you suspect TB meningitis and they have pulmonary disease, and even if they don't, sometimes we do gastric aspirates looking for pulmonary TB. There's a host of other tests I won't go into that are talked about in favor in one article and disfavor in another that have proven not to be particularly reliable, including PCR of the CSF. How do we treat TB meningitis? So there's a variety of ways to do it, but we use the standard medications, isoniazid, rifampin, pyrazinamide. Depending on who you read, for example, ethionamide is recommended by the American Academy of Pediatrics as the fourth drug, but also you can, in place of that, you can do streptomycin or one of the other immunoglycosides. Fluoroquinolone sometimes used, although they're not currently recommended. These are the doses they're used. We try to go towards the higher end of the dosing range because we want to get as much across the plate, as much medication across the inflamed blood-brain barrier as we can. And oftentimes we're dealing with, as you'll hear from Suzanne Chargarello in a minute, adulterated medications, refreshing tablets or making up suspensions. And so we want to use as high a dose as possible to get effective treatment as possible. Probably the other key treatment that helps reduce inflammation, vasculitis, and ultimately intracranial pressure is the use of prednisone. We use prednisone or prednisone equivalent of 1 to 2 milligrams per kilogram. It lowers mortality rates and does help reduce long-term neurologic sequelae. So those are the medications we use. Again, clearly the big three are used, and then you can shift in the ones, I guess, that you're most comfortable with, because there's no comparative trial saying what's better and what's not. Finally, we deal with child-unfriendly medications. All treatment should be by directly observed therapy. TB meningitis cases are one of the two cases where I routinely monitor liver transaminases, because miliary disease and TB meningitis put children at higher risk when they're on TB medications of developing elevated liver enzymes. So, and then, of course, you always want to follow the susceptibility studies of any isolate that you get. And push hard to find the adult who infected the child. So the abridged version of what I just presented to you is sort of this. Tuberculosis should be suspected as the cause of meningitis when the meningitis is accompanied by cranial nerve involvement, hydrocephalus, evidence of inflammation at the base of the brain, suggestive CSF findings, a history of TB exposure, or relation of some sort to someone from a high prevalence country of birth, be that the child's parent or a visiting relative or friend, a chest x-ray that's suggestive. The other thing to remember, there are very few infections that we can treat in children that cause encephalopathy or a change in behavior or personality. TB is one of them. So whenever we're consulted on the infectious disease side to a child who's behaving or acting unnaturally, unnormally for them, TB is always on our list, and we may start treatment until we sort out the details. And then finally, even consider that a child has TB meningitis requires a high index of suspicion because of the way it presents. It's difficult to diagnose even when you say, I think this is TB meningitis. It's really hard to confirm the diagnosis. Particularly because there's no definitive test available that makes the diagnosis quickly. It often causes doubt in the eyes of the clinician. Part of what I do a lot, if you've spoken to me, is I try to encourage when the suggestions are keep treating, wait for the cultures will tell you. And particularly when it sounds like a kid's a TB meningitis. And having that index patient is really, really very helpful. Finally, delayed diagnosis is frequent with a poor prognosis as a result. Early diagnosis, good prognosis. TB meningitis, if caught early, is readily treatable, and is clearly preventable if we can identify the adult cases ahead of time. Perhaps identify them when they arrive and treat their LTBI before they develop TB disease. And I think I'm going to stop there. Thank you very much.
Okay, thank you, George. Let me go ahead and introduce the next speaker. Susan Potoloni, and she's going to teach us today about the administering medication.
Thank you for inviting me to speak about administering TB medications in children. Okay, so a little bit of sugar helps the medicine go down.
We all remember Mary Poppins talking about that in the famous movie. Administering medications. When the diagnosis of pediatric TB is made, the challenge is how to administer TB meds to young children presents itself. TB medications are not formulated for pediatric patients. Medications are large, foul-tasting pills and capsules, not easily given to infants, toddlers, and preschoolers. Only isoniazid is formulated in this suspension, but the sorbitol in this often causes cramping and loose stools, and it's best to avoid this. And normally we do not use INH syrup because we found that absolutely this is true about the cramping, and if the dose is amenable to give to a young baby, we use the pills, and we need to teach the family how to administer the medication. So steps to successfully administering medications, first of all, you have to start on day one of teaching the caregiver how to administer the medication to children. Because even though in TB and pediatrics we use directly as their therapy, we know that on weekends the parents are the ones, or the grandparent, or whoever the caregiver is, that should be giving the medication. My most important recommendation to anyone giving medication to children is to keep the volume to the smallest amount possible. This is the key to success. And the goal is to administer all 4 TB meds in less than 2 teaspoons. Now, some people think that that's not possible, but we have done it. I've been here 14 years, and we've been doing it before that and since I've been here. And we take the pills and crush them to a fine powder. And with the capsule, with the rifampin capsule, we open them and add the powder to the crushed pill. And then you add a very small amount of warm water, and I think the warm is the operative word there, because when you add the warm water, it dissolves the granules, and you're left with either a paste or a small amount of liquid. And then finally, you add something to that that the child likes, either fruit, yogurt, applesauce, juice, or anything the child would like that will allow them to take the medication and not spit it out or vomit it. And administer the medications either with a spoon, a medicine cup, or use an oral syringe. And when we use the oral syringe, you don't want to aim it in the middle of the mouth towards the throat, because that tends to make the child want to retch. You aim it towards the inside of the cheek, so it'll just trickle down the throat. And then for infants who are only on either breast milk or formula, we mix the medication with the milk, and then take the bottled nipple, place it in the baby's mouth, and add the milk medication mixture for the baby to suck. And we've been very successful with that method with infants. Other suggestions, besides knowing how to prepare and administer the TB meds, one must be mindful of the child's developmental level. So we have to do things to make the child take medication, such as distraction with toys, waving things in front of the child's face, music. With an older child, you might use rewards like stickers, small toys, even M&Ms. This one is the most important. Don't delay the process, be quick. Because oftentimes parents are negotiating, the child is running around the house. You have to be firm. The adult is in charge, not the 2-year-old, not the 3-year-old. And they're going to oppose having to take whatever you're trying to give them. So you have to be in charge, be firm and focused. They have to hold the child, restrain them to some extent, because remember, our goal is to give them the medication. And you have to establish a routine, because remember, children love routine. They love things to be over and over, like a story. Read me that same story over and over again. And this gets established as a routine like anything else. So it may take up to 2 weeks before you're successful with the medication. And medications are our only weapon against TB. Therefore, we must be successful in providing the medications to cure the child of TB. I just want to mention the article that was in Pediatric that was published in 1986 by Noderman and others about the effect of dose formulation on INH absorption in 2 young children. In this article, which many practitioners have read and raised concern about the crushing of pills, they had a problem with one child who was getting the INH pill crushed, and there was child wasn't improving on this method. And when they did levels, they compared the crushing of the INH pill added with apple juice. Then they used a parental dose of INH with apple juice, and then the INH syrup. And unfortunately, in this particular child, the INH crushed pill showed the lowest absorption, and that led them to believe that perhaps that's why there was the child did not improve. So my take on this is, number one, both preparations were added with a sugary substance, the apple juice, the third being the syrup, which is also a very sweet mixture. So perhaps because they just crushed the pill, and this is only my thoughts about this, that they didn't dissolve those pills, and that perhaps many of the granules stayed in the child's mouth, under the tongue, in the cheek, and maybe the whole dose never got to the stomach. That's why we recommend dissolving the tablet before you administer it. And the other important thing I want to say is, whenever you alter a medication, it must be administered immediately. You can't prepare the medication for delivery and have it sit for a half hour or an hour. The medication is prepared and the medication is given to the child, because we don't want to have an adverse effect on the medication's purpose by adding things to it, by waiting. So it's very important to teach that when you're teaching parents to give medication. Thank you.
Okay, thank you, Susan. Our next speaker is one of the TB nurse consultants for the state, Ms. Karen Galanowski, and she's going to talk to us today about the nurse case management of pediatric TB meningitis.
Okay. Thank you very much, Suzanne and Dr. McSherry and Frank, for all of your information. I'm going to talk about nurse case management, and I'm telling you we couldn't do it without Suzanne Tartarelli, because she is our expert when it comes to how to give the medications and how to teach the parents, and has taught us all so much in this process that I really want to thank her from all of us nurse case managers in the state. She goes to the home, makes visits with the nurse case manager in all the counties. So it's been a godsend for us. Pediatric TB meningitis, as we know, is a sentinel event. It's a very sad event, and it's a priority for public health action. As we know, the nurse case manager must consider this a priority and be given the time to visit the hospital within 3 business days of the report, or sooner if possible. I know that's in our standard, the 3 business days, but you know, sometimes it can get delayed because of time, but in this situation, it's really important. With any, it's important for anyone to get to the hospital within 3 business days, because that adult may have a 4-month-old child in the home that you really want to get to and evaluate as soon as possible to prevent these cases of TB meningitis. So I recommend that the nurse case manager actually go to the home for the first visit. I know in a lot of situations our public health representatives are excellent, and they're great at establishing a rapport, but either on that day or soon thereafter, the nurse case manager has got to get in to establish a rapport with the family, significant others, and the child, you know, so they can develop this relationship. But even more important is to develop a relationship with the hospital providers, because things change at a moment's notice in the hospital. You think you know what that kid is on, and the next day you find out the whole thing has changed. And unless you develop that relationship with the doctor, someone else, whether it's the infection control nurse, the case manager on the floor, the nursing supervisor, whoever it is that you call, they'll call you when there's a change, because we've had significant changes. Patty and I were in Atlanta, Georgia, when we got a call a couple of years ago about a kid who was being placed on hospice in CHOP. And we said, what? Everything was going along okay. So we said, wait, don't stop the TB medications. Please keep giving them. We called Suzanne, Dr. McSherry. They intervened. The child is finishing treatment Thursday and is doing so well. Has no, has a little bit of a left-sided weakness, but is walking and talking and happy. So, and that kid was going home to die. So that's how things can change so suddenly in the hospital. So it's that relationship that's really important. And of course, we need to know also what, that there is a case of TB meningitis or a kid with any TB in a child. So contact either Patty or I at the State Health Department as soon as you find out. It's very important on that first visit to review the medical record, of course, find out about the symptoms upon admission, what they say in the hospital, and then, of course, what the parents say. Radiographic findings and dates, bacteriology collected, site, and AFB smear results. If you don't look at the record, you get all kinds of information from people in the hospital. You really have to review that record and take a look at the written documentation. There are other laboratory findings, as we said, like the protein, the glucose, the child's cognitive status, and other coexisting medical conditions the child may be previously diagnosed with. On the hospital visit, also it's important to interview the family members. Families are devastated with any kid with TB. So if you get a sick baby with TB meningitis who's in a coma, it's even more devastating. And their main concern is the welfare of that kid, and they may not be interested in having a chat with you. That's why the relationship, the one-to-one contact with that family member or families is so important. But at some point, you have to find out and talk with the family members, either there or back in the home, to obtain past and most recent medical history of the child. As Dr. McSherry said, we want the following questions answered. Was the child ill or symptomatic? What were those symptoms? Their onset and duration. Did it happen a couple of months ago, 6 months ago? Were they seen by a medical provider? Who, where, when, and how many times? We really need all that information. If we're going to take a step back and take a look to see where this could have been missed, we need to know who saw them initially and when did they see them again and again. And also to gather more information about the diagnosis. Were previous procedures, such as a chest x-ray or CT scan, done where, when, and by whom. Identify a hospital contact, I said before, who will be able to communicate accurate, complete, and current information. You call the ICT, and that's your contact. She or he may not have the current information. You ask them to go to the record and talk with you from there. We want treatment start dates and changes. We frequently find kids started on RICE, or INH, rifampin, and PCA. Ethionomide is frequently left off, which is penetrates the blood-brain barrier better than some other medications. And prednisone is generally not started with these kids with hydrocephalus. We need all the current medications, dosages, frequency of administration, and method of administration and changes. The kid I spoke about really got very sick in the hospital because they were splitting doses of rifampin, and the child was vomiting for the first 2 months of treatment. And this wasn't communicated back to the case manager. The case manager was calling, in touch with hospital staff, but how the medications were given and the child vomiting the medications probably caused her meningitis to become more severe during the course of treatment. So we really need to find out how they're giving it, what time of day, what's given, and then we'll get our experts, Suzanne and Dr. McSherry or our other pediatric experts, TB experts, to call and discuss the treatment options. It can change, as I said, overnight. We want to take a look at bacteriology. We'd like them to collect CSF or get some specimens so we can then do the genotype to actually see if we have the right source case, and any procedures or tests conducted with results, and of course the changes in the child's status. You hear all kinds of things. You get a call from the hospital. Well, they're taking the patient off the ventilator. Patient's not doing well. The next 2 hours, they're not taking the patient off the ventilator. So it's really hard to figure out what's going on in that hospital. And you don't have time to go every day, so you really need that contact. As we've all said, the priority is to find the source case. Once we get the child on the right treatment, the next priority is to find the source case. So the contact investigation should begin right away. It shouldn't wait for somebody to come back from vacation or whatever. Someone needs to get out to that place of residence. Who lives in the home, who's lived in the home for the past 6 months or the last year even, if people remember. Names and addresses of caregivers, daycare centers, country of origin of the child and or the parents or other caregivers, previous travel history. In 2 of our TB meningitis cases, the babies traveled to another country. One was Haiti, a high-incidence TB country. She was there for 3 months. And the other was to Costa Rica, a low-incidence country. Parents were born in Costa Rica, child born in the U.S., was there for 3 months. And that we did not find the source case either. No one was sick around that child, according to everyone that was interviewed multiple times. So, but that case was missed primarily in the hospital because the child was from a low-incidence TB country and thought not to have a TB risk. So there's no easy answer for this. And prior risk of TB exposure. Did somebody else in the home have TB? And to go to the home, verify the address, determine the names, ages, countries of birth, symptom assessment of everyone who lives in the home, provide PST or QFT right away for all contacts. Of course, if anyone has symptoms, get them to be evaluated or hospitalized. Provide, refer children greater or equal to 5 years of age, regardless of the skin test, to one of our regional specialty pediatric clinics, because children can have a negative skin test and still have full-blown TB. And follow all those with a skin test, with quantiferon gold, with a positive quantiferon gold, with a chest x-ray and medical evaluation. Our regional TB specialty clinics see all kids suspected or diagnosed with TB disease who are identified, those identified as a contact to a case of pulmonary TB and Class B1, B2 immigrants. Any of those, regardless of where they live in New Jersey, they can be referred to our regional chest clinics. Referrals should be made by the county nurse case manager in collaboration with the New Jersey Department of Health TB program consultants. And our regional chest clinics are at Lattimore, Hudson County, and Belmar. Once again, collaboration and communication is essential with the nurses at Lattimore practice. And Lillian Pirog, the nursing manager, and Suzanne Tortorelli are excellent resources. Nursing challenges, including how to administer medications and issues, go to them all the time. Can't thank them enough. And of course, our expert pediatric physicians are also available to consult with hospital and primary care physicians regarding treatment and what procedures would be recommended. So the challenges, in summary, are treatment issues. How medication is given, is the child on the right medicine, and what is the change? Other issues are insertion of PICC lines to give them medications and G-tube for oral medication and feeding. These kids have had all of these. They go home with some of these. Medications given in oral suspension with doses 2 to 3 times a day is a problem we see for the child. Causes diarrhea or vomiting after large amounts of liquid suspension. And then no absorption and no absorption, worsening condition and treatment failure. And we know from experience, unfortunately. TB meningitis in young children causes neurological deficits, including psychomotor impairment, eating difficulty, function, and loss of developmental milestones. So post-hospitalization, all of these children require a lot of time for the family. There's PT visits, speech, occupational, at least weekly, sometimes 3 times a week. Monthly visits to a neurologist, monthly visits to the TB clinic, social services from the community trying to assist with pediatric daycare, for instance, transportation to all of these PTSDs. So it's very challenging for a family and can be challenging in providing DOT. We actually had to go to Skype because the father, the child was out almost every day. The father had him, the one who was finishing treatment, so successfully in PT, OT, and speech almost every day. So we actually had to go to Skype during the course of the treatment. Once a week, the nurse case manager went. So it becomes challenging, and you have to be flexible and work with the family. In-home 8 to 16-hour nursing care is sometimes necessary, as well as pediatric daycare. So it takes a village to treat these kids. There are multiple healthcare providers. We can't forget the primary care doctor, and the primary care doctor has to be kept in the loop of all of this. Social services are needed in the care of this. This needs to be recognized by the supervisors of the local TB programs, the health officers, the nursing supervisors, to allow the nurse case manager time to really case manage these pediatric TB cases. Collaboration and cooperation among all parties involved leads to the most successful outcomes for these children and their families. Thank you.
Okay, thank you, Karen. I wanted to mention, before we bring in our last speaker, was to remind you all that, we had 7 cases of TB meningitis reported in New Jersey in just under 2 years, the last 2 years, and 2 of those cases occurred in Ocean County. So we thought it would be good to bring in Patricia High, who's an epidemiologist down in Ocean County, to share with us her experiences with these cases. Patricia, are you there?
I am here.
Okay, take it away.
Basically, so in TB meningitis in Ocean County, we're going to see, based on some of the previous speakers, that it ended up being a very textbook case. We had recent real-life cases with experiences as a local health department that led us into learning a lot about what actually occurred. So I'm going to breeze through these next couple of slides, just they're a backdrop of TB meningitis and some of the rates of incidence, which I know Frank and Dr. McSherry sort of already discussed. But it remains just critically important with TB meningitis and obviously any pediatric TB to keep that high index of suspicion and to make an early diagnosis. We've seen in Ocean County where that level of suspicion is not nearly as high as we'd like it to be, and that was again seen with the case that we're going to outline here today. So basically TB meningitis in children, again, Frank hit on all this, so I'm just going to breeze right over it. He discussed the presence of TB meningitis in the U.S., including about 5%, and in New Jersey, 4% of cases annually. So what happened in Ocean County? June 26th of this year, we had received a report from Jersey Shore University Medical Center that there was a suspect TB meningitis in a 22-month-old Hispanic child that had recently just transferred from an Ocean County acute care facility on the 21st. Later that same day, we received a second phone call from the nurse case manager there, slightly panicked that the 4-year-old sibling of the suspect patient had just presented to the ED with comparable meningeal symptoms. So for us, it was kind of an immediate alarm, obviously even with the first case, and now to have a second case of meningitis was certainly alarming. At first, they weren't sure if it was TB, and now all of a sudden we had 2. And so working with the nurse case managers at the State Department of Health, we began to look deeper and quickly into this, including the immediate initiation of a source case investigation and medical record review. We did start that. What we found right off the bat was, again, very stereotypical of what we see with TB meningitis. We had 2 U.S.-born children with foreign-born Hispanic parents from Mexico. Both of them had presented to the ED. What had happened with the 22-month-old, however, was that he had been seen for numerous acute care visits at the local ED with upper respiratory tract infections and other respiratory presentations. So starting from 3 months of age, he presented with, cough and other respiratory symptoms and was discharged. Another 3 months later, sore throat, cough, shortness of breath, and the rest, including perihilar markings on his chest x-ray. And they tested him for flu, and he had come back flu negative. He was again discharged. 3 months thereafter, again presenting with significant respiratory infections. He had an abnormal chest x-ray at that time. They had done a comparison to the February chest x-ray. And he had increased tissue density in the paratracheal region, lymphadenopathy, upper and middle lobe infiltrates, and was again discharged. So just 1 month later, he presented with fever, weakness, vomiting, and visual changes that had started that morning, and was then transferred out to Jersey Shore because he'd become unresponsive. Signs of acute hydrocephalus were documented. He was needing intubation, and they did document a paratracheal mass with then central necrosis in a chest x-ray. So we'll discuss this further later, but just again, the failure to really consider or even include TB in the differential diagnosis up to this point was missed all the way through the child becoming unresponsive and then transferred out. So once he was transferred over to Jersey Shore, testing for TB was done. They did initiate empirical RIPE for the child, which was later changed from ethambutol to ethianamide based on recommendations from the nurse consultants in Lattimore Clinic. He ended up going on to have a positive skin test and then ultimately a positive sputum for mycobacterium tuberculosis by probe. And I know that that's something that we don't always get the opportunity to see. Frank had said that it was only in 9% of the cases that we had seen. However, they were able to get that. So moving into the source case investigation and some of the contact investigations that we initiated right off the bat was that we found 24 very close contacts to really both of the children. 15 of those 24 contacts were household contacts that were all living at the same residence in Lakewood. They were all Mexican-born immigrants. The children in the home were all U.S.-born. One of the contacts was hospitalized with symptoms compatible with TB, and he was the one that had presented and was later diagnosed with TB meningitis at Jersey Shore as well. An additional contact that we had identified at the time of skin testing was referred actually immediately to the local emergency department because of the TB nurse case manager here, who was a student, identifying the fact that he presented with ongoing cough of an extended duration. At the time that he was admitted to the hospital, we did give the facility a heads up. He was immediately placed on isolation and did come back positive for pulmonary tuberculosis. 4 contacts were lost to follow-up. It's difficult for us to assess who the true suspect index case was. We did have an adult diagnosed with pulmonary TB. However, with the early onset of disease in the 22-month-old, there is concern that there may have been an additional adult within the home that may also have had pulmonary TB. We were not able to ever contact this individual, as the family of the 22-month-old had evicted him from the home upon diagnosis of their child with TB meningitis, and part of that was because of a long-term history of coughing within the home and an otherwise sort of non-familial kind of attitude and environment within that home. So some of it at times was anecdotally reported that the individual had coughed so hard that he fell over. So while we can't say for sure if our pulmonary TB was a source case, we did know that the potential for exposure within the home was no longer occurring. So these are sort of the epi considerations that we looked at. Again, 24 total contacts, 15 of which were household contacts. We knew at the time, within about 2 days of being first informed, that 6 contacts were aged 5 years or less. A total of 10 were under the age of 15. 12 total contacts tested skin test positive, including almost all of the children, which were started on empiric treatment right off the bat, some of which were weaned down thereafter. We had a total of 3 TB positive cases through the course of this investigation, the initial 2 pediatric meningitis cases that were in the siblings, again 22 months of age and 4 years of age, and then the 1 pulmonary in a 19-year-old adult. The 4 were also lost to follow-up. So again, as we saw with some of the earlier presentations, TB meningitis, especially in children, is significantly severe. It is life-threatening. It is concerning for any family, and there are certainly risks. They can include seizures, hearing loss, the increased intracranial pressures, brain damage, stroke, and death. We have seen those things. Again, fortunately, we don't see much pediatric TB death here in New Jersey, which is great. Our case experienced a number of these things. He did experience seizure. He had right temporal meningitis, Sylvan-Fisher meningitis, the acute moderate hydrocephalus with a hemorrhage at the catheter tract. There was the necrosis that had been identified in the chest x-ray that was abnormal prior to his most recent presentation with meningeal symptoms. And he did end up requiring a G-tube tracheostomy and has had and continues to have significant psychomotor delays. So in addition, again, to the RIPE regimen that the patient was put on, he also required a lot of other drugs in order to manage the additional symptoms that presented based on the sort of late diagnosis. Steroids, prednisone, antidiarrheals, antispasmodics, anti-seizure medications. He was needing to be rehospitalized. He's been hospitalized at least twice since his final discharge. He requires ongoing in-home nursing care. There is a nurse that lives in the home, in the patient's room, providing some of the DOT and helping with a lot of the care when the child is not at a pediatric daycare, and he does receive weekly special child health services. One of the things that that we've really seen is that human aspect of treatment for TB with a child, with any child, and our nurse case manager has just done a really great job with it. But it's not easy for the family, like Karen said. When you're talking about having one child with TB meningitis, it's one thing, and the parents had actually both surrendered their jobs in order to care for the child at the time of diagnosis, and then to have a second child under the age of 5 also present with meningitis. It had long-term consequences for this family, long-term clinical consequences, dealing with having a potentially special needs child now for the rest of your life is of significant concern. With that, it did create compliance with both medications as well as additional contact investigations and testings. It made that process really easy for us because it was very easy to say this is the consequence of what could happen if you fail to take treatment, if you fail to complete the drugs. However, it's really worth the price of what we see in the family. So, financially and socially, medically, all of these things really come into play in any real-life situation. For us in Ocean County, I think one of the things that we find the most frustrating and can be frustrating for anybody dealing with pediatric TB is the missed opportunities. We struggle with that here, just not seeing a lot of TB annually. A lot of our physicians are unfamiliar with the diagnosis of TB or its presentation. So we had a 22-month-old that had been seen in an acute care facility 5 times between the ages of 3 and 22 months with cough, respiratory, meningeal symptoms before TB was ever even thought about, before a physician ever considered it, before a physician ever picked up the phone and called. Despite opportunities to do that, despite infiltrates and lymphadenopathy on chest x-rays, despite increasingly abnormal chest x-rays, living, in foreign-born homes with transient individuals. I mean, just your sort of textbook TB risk factors, and it was never brought into the picture. So, from our side, there is that desire and that need to see the clinical index of suspicion raised throughout our county and especially within our acute care facilities, our ID physicians and pulmonologists, including at the pediatric level. Some of the public health implications for us, and I will, wind down with this, is that the case investigation, like Karen said, it does require significant and timely contact investigations. It's never an easy process. It's never something that's going to, kind of be quick and done with. But we do see that it leads to a lot more. For us, it initiated 5 pediatric DOTs for us, an adult DOT, having to worry with the acute care facilities as to whether or not the individual will be allowed to return home based on other high-risk, individuals and pediatric cases within the home, 6 LTBIs that were initiated. And so the ongoing case management of this entire household has been quite significant. We were talking about DOTs, that initially lasted up to an hour, just making sure that the children were able to take the dosages that were being prescribed and that the adults were doing so as well. We were able to further develop and improve partnerships with some great organizations throughout New Jersey. Obviously, we work all the time with the Lattimore TB Clinic. However, it was for us the first pediatric meningitis that we had worked on. So both from the pediatric side with Suzanne as well as the meningitis side with Karen, it was excellent. We worked with our local children's specialized hospital. They provided some long-term pediatric care after discharge from acute care up at Jersey Shore. And then also, you know, local therapists and special child health services, including those from the health department itself, have come in now to sort of pick up what's going to be an ongoing opportunity for services for this individual. So we do work collaboratively. We learn from each other every day, and you know, we're super pleased to do that. But again, it's always going to be our hope to catch these cases as early as possible in the course of their care so we can avoid some of these things going forward. So that's it for me, Frank.
Okay, thank you, Patricia. I also wanted to thank you and all the folks down in Ocean County for the tremendous effort you all did with that contact investigation. You know, you may have capitalized on some opportunities for prevention among the children in that home, and so I think that should be recognized. You know, it obviously could have been much worse. We are scheduled to conclude this webinar at 2 o'clock, so we have about 5 minutes. We want to take some questions for any of the speakers. I think we have one question in-house. Yes.
Thanks, Frank. Hi, this is Lee Reichman from Global TB Institute. Congratulations to the health department and partners. This was an outstanding presentation, and I hope it's archived and available for people to listen to. You know, this is a major tragedy, but it's nothing out of the ordinary. You know, we see in the United States 2 or 3 outbreaks of TB per week that make it into the newspaper because someone comes into the emergency room, whether it be adult or a child, 5 times and gets diagnosed each time as having an upper respiratory infection. So this is a tragedy, but this is also a teachable moment. And, you know, if I'm a surgeon, and our surgeon's sitting behind me, so he can hit me if I say the wrong thing. If I'm a surgeon, I have to present my surgery results at a special conference every week or every month where they evaluate and castigate me for untold complications. If I'm an internist, I have the same kind of conference where they discuss the mistakes that we make. Now, the only people that have the information that you're showing here and can put it all together is the State Health Department. And I'm wondering what kind of teachable moment besides a webinar like this the State Health Department can do. It would seem to me that if I'm the physician in the emergency room or his boss in Jersey Shore Hospital, who's turned away a kid who was coughing 5 times and his brother who's also coughing 4 times, a letter on State Health Department stationery saying you did this and you did that and you shouldn't do this is really a daunting process, and that person will think twice before making that diagnosis again. And I think, you know, you guys, Health Department I'm talking to now, are good guys, and we love working with you. But I think it's time when you got to hold the feet to the fire to them or us when we make these kind of terribly tragic mistakes.
Let me let Karen Galanowski address that. We do have an effort underway to reach out. But remember that the onus is really, you know, what we see is that it's on the local health departments, as, you know, New Jersey is a home rule state, to really develop that relationship with the emergency room physicians, pulmonologists, ID docs in the county. The state health department does not have the administrative or the regulatory authority necessarily to, intervene in this way now. But so we'd rather do a more non-invasive interventions. Karen, what was our effort with?
Well, we have a plan, and we were going to be instituting the plan of meeting with the one hospital that failed to diagnose that one child after 5 different visits. These are residents in ERs. We need to meet with hospital administration, infectious disease, with the Ocean County Health Department, and then to discuss this, and then set up an in-service, pediatric TB in-service. We were going to do it in the fall, then the flu season, and then the Ebola hit, and so now We're going to be meeting in January with Patricia High and Pat Shaker at the Ocean County Health Department to visit. I think we need to visit all the hospitals in Ocean County. With the other cases that were missed in the pediatrician's office, I have been visiting in person to the pediatricians and giving them the CDC curriculum because these were missed pediatric cases, but in one case was a missed adult case that caused this one child to, and the grandfather had been to the doctors for 6 months and given different antibiotics with a cough, increasing cough, and he was found while he was visiting the child in the hospital. The hospital luckily did an x-ray and admitted him, and his genotype matched the child's. The father also got TB, pulmonary TB, and the uncle. So in that situation, I visited the adult doctor who missed and been in contact with the pediatrician. It's as Dr. McSherry said, it's difficult for these pediatricians to pick up the sequela of illness early on, which needs to be picked up early on, especially when the suspicion for TB isn't there. So how we influence the private physicians is still a big question in my mind in a broader scale. It would be nice to be able to do that, to really get to them and maybe buy a written article about how to diagnose TB, what you should look for is a starting point. If some of them had just done x-rays initially, chest x-rays.
The State Department and Karen, especially who I've worked with for probably 20 or 30 or 40 years, has done a spectacular job in this. And I think that you need a crisis. I mean, when you go down the wards of the Children's Specialized Hospital and see 4 of these 6 kids there who are crippled for life, look and see how many Ebola cases you're seeing in the Children's Specialized Hospital there. And yet the tremendous outcry that we have looking for Ebola, well, in the meantime, we're letting our own homegrown kids get crippled for a disease that's not preventable and diagnosable. And I think that you need, the health department, your bosses, and I'm not, believe me, Frank, I'm not castigating anybody, but I think you guys need to use it to bring your bosses to say that, hell, yes, we'll be ready for Ebola when it comes, but meantime, we've got to use this crisis to embarrass a few people. No one in Jersey Shore Hospital wants to be embarrassed. And yet, if this comes down to the diagnosis was missed and this kid is going to be a hemiplegic for life, then that's never going to happen again in that hospital because the bosses in Jersey Shore Hospital are going to make sure it doesn't happen again. That this is tragic enough that we should use this to raise hell with. This is a teachable moment. These kids are not going to be recruited, but you should prevent it in other kids.
Now, as a surgeon, I want to tell you the lack of awareness of the incidence of tuberculosis today in this country among the general practitioners and the internists. And yesterday I was asked to see a child, an adult, with pericarditis. And I said to the internist, did you get a skin test and a quantiferon gold? And he turns around and says to me, what's a quantiferon gold? Now, I'm a surgeon. And because I was taught by Lee, he drummed this through my thick skull. But, you know, they don't have the general knowledge that they should have, and they're not aware that TB is an active problem today in this country. They just have no confidence, but we got to change that somehow.
Right, and we know about the cycle of neglect, and I know that Dr. Eichmann has outlined that very well in publication. So, you know, that is the challenge, I think, as, you know, incidence continues to decrease, you know, we become more and more, you know, less attuned to what is going on. I think, like Lee mentioned, you know, the hospitals that have been affected, you know, then become hypervigilant. It's the hospital, we can't predict where the next child case is going to be diagnosed, or the next pediatric meningitis case is going to be diagnosed. So, you know, it's kind of a moving target. So, I mean, the education effort continues in New Jersey. You know, I know in this venue, more or less, we're preaching to the choir, but we're at least trying to get that word out. I think if, again, the county health departments can establish good working relationships with the hospital ERs, but again, in many cases, these are revolving doors, like we mentioned. You know, you have, even if you gave an educational in-service to a group of interns, you know, in a short period of time, they're all gone. So now you got to do it again. So, and we in many ways lack the resources to continue that effort.
That's not your responsibility. That's the responsibility of teaching hospitals. Make sure the
Agreed, yes.
informed every year. I would worry about you taking responsibility for that.
Dr. Mays?
Well, Dawn.
Oh, Dawn, I'm sorry.
Okay, Frank, I think this is excellent, and I really think a lot of TB programs nationwide should use this information. I mean, there's very few TB programs that actually have 2 households, small children that has experienced this. So I would recommend that we try to get this on maybe an NTCA agenda in a breakout session or something at that point. I think a lot of programs could use this.
Okay. I think we're working on something for TB notes, at least preliminarily here. Yes, ma'am.
Yeah, hi. This is Sundari Mason. Fabulous presentation. Thanks to all the presenters. So just one comment and one question. What we're talking about is TB notes, NTCA, and those kind of venues that reach people who are in TB already. We need to have a way to reach people outside of TB. I think that's kind of what Lee was saying as well. So my question, though, is very clinical. And Dr. McSherry, can you just quickly discuss the reason why you choose ethionamide instead of ethambutol for your regimen? In adults, we don't use ethionamide.
Well, first of all, it's well tolerated. Second of all, it crosses the blood-brain barrier and achieves a level in the spinal fluid that exceeds usually the MIC of the organism. And we replace, there's a question about how effective ethambutol is in that particular regimen for TB meningitis. So following a lead from the South Africans, we sort of moved to do that. And in actually the Red Book, which the American Academy of Pediatrics, they put ethionamide as their 4th drug, although they'll say ethionamide or an aminoglycoside, streptomycin application.
Okay, thank you.
Okay, well then that will conclude today's presentation. For anyone who's still with us out there, we appreciate your participation. Thank you.